Hi, this is Governor Pete Ricketts, and welcome to the Nebraska Way. We are so excited to be resuming our podcast after the hiatus during the pandemic. And today we've got a great guest who is going to be able to talk to us a lot about the pandemic. So really a great way to bring back our shows after almost 16 months of not doing podcasts. And of course, as you noticed, we're actually making the improvement now of being able to do the video along with it too. So it's really exciting. So today I'm being joined by Dr. Bhattacharya, who is a professor at Stanford University. And okay, Jay, I'm actually going to read your bio because it's actually pretty accomplished. Usually when we're back at the audio days, I would just read it, but nobody could tell because I wasn't being on camera. But now I'm going to see, I'm going to look down and read your bio. But it's actually pretty impressive. So it's worth me getting word for word as opposed to just kind of making it up. So Jay Bhattacharya is a professor of medicine at Stanford University and a research associate at the National Bureau of Economic Research. He directs Stanford's Center for Demography and Economics of Health and Aging. Dr. Bhattacharya's research focuses on the health and well-being of vulnerable populations, with a particular emphasis on the role of government programs, biomedical innovation, and economics. So that's a pretty unique combination that you pull together. That's really fascinating. So that's going to really be a cool conversation today. Dr. Bhattacharya's recent research focuses on epidemiology of COVID-19 as well as an evaluation of policy responses to the epidemic. His broader research interest encompasses the implications of population of aging for future population health and medical spending in developed countries, the measurement of physician performance tied to physician payment by insurers, and the role played by biomedical innovation on health. He has been published in 135 articles in top peer-reviewed scientific journals in medicine, economics, health policy, epidemiology, statistics, law, and public health, among other fields. Holds an MD and a PhD in economics, both earned at Stanford University. So Jay, it is great to have you on the show. Thank you so much for joining us.
Thank you for having me. I appreciate being here.
All right, great. So let's jump right in. You obviously have had a broad voice in this conversation over the course of last year with all the different areas that you touch upon with regard to the pandemic. And I will tell you that as I was going through this, I was talking to one of our doctors here in the state, who's an epidemiologist. And I said, hey, so great, you're talking to me about COVID-19, but what about increased child abuse, increased domestic violence, increased drug overdose, mental health issues, suicide rates, all those sort of things? And his response back to me was, yes, Governor, somebody should be looking at those things, but I'm an epidemiologist, that's not my job. And that, of course, as somebody who's trying to make policy decisions, doesn't leave you very warm and fuzzy. So you obviously have a very deep background, a broad background on a lot of different topics. Talk to us a little about kind of what you've been doing over the course of the last 16 months or so with regard to the pandemic and the types of research you've done or how your background has applied over the course of the last 16 months as we've gone through this pandemic, and how such a diverse interest has really played into your bigger picture thinking, if I can call it that, with regard to how we look at the pandemic.
Governor, thanks for that question. I mean, I think it's one of the biggest tragedies of this whole pandemic that public health forgot that it's about public health. It's not just supposed to be about infection control. Right. It's supposed to be about so many other things. And your comments about child abuse, domestic abuse, a whole host of things, cancer treatment, cancer.
All right, let's think about that. Yeah.
Diabetes management. I mean, all these things are terrible problems that we absolutely have to address, continuously before the pandemic and after. And the pandemic, the tragedy has been we forgot about. I'll just give you one set of numbers. Like I think something like identified child abuse dropped by like 50%, something on that order. Well, it doesn't mean that child abuse didn't happen. It's that child abuse tends to get picked up in schools. And so many places close schools. And so children are at home suffering with no adults there to pick up the fact that they're being abused. I mean, that's just, it's one thing, but it's a major thing.
We absolutely saw that in Nebraska, where we saw the calls into our child abuse hotline fell off dramatically in the spring of 2020 when our schools went to remote learning.
Yeah, of course, in Nebraska, you all stayed open for much of the rest of the year. I mean, which is a huge bonus. In California, my kids didn't go to public school. They didn't go to school actually for 16 months. And I think it's one of these things where uh, society and health are so deeply interconnected. You change one thing and you think, okay, I'm just going to change that one thing. But something like a lockdown, it changes so many things. It disrupts systems that are intricately woven and aimed to keep people healthy, and we just forgot about that. And it's shocking to me that so many public health officials did forget that. It was one of the very first things I thought about when I heard about the lockdown was the fact that we're going to see so many other systems disrupted. I'm going to give you another one outside the United States, but still, I think connected to the lockdown, the morality of the lockdown. In April of last year, the UN estimated that there would be 130 million additional people starving or at the brink of starvation worldwide as a consequence of the economic dislocation caused by the lockdown. 130 million. And of course, the US plays an enormously important role in keeping the world economy afloat. I mean, in a sense, we're indirectly connected to those 130 million people. Starving.
Has there been any follow-up on that? I mean, have they seen the actual data with regard to what has happened since the pandemic started?
So in February of this year, there was a paper published in Science Advances, I think, that's estimated from a massive survey in developing countries of 90 million plus people who actually were put on the brink of starvation or into poverty. The UN, another estimate from just this year, in April of this year, 220,000 children died from starvation in South Asia as a consequence of the lockdowns, worldwide lockdowns. I mean, it's one of these things where okay, so COVID is a terrible thing, absolutely terrible thing. 3 million people have died of it, 600,000 in the US. And yet we're talking about tens of millions of lives impacted by the thing that we use to try to address it. We basically thought to ourselves, all we should be thinking about is the benefits of lockdown, as an economist, what do you think about? You have to compare benefits and costs. Somehow we pretended that there were no costs to the lockdown.
Yeah, so that's a great question. How do we adjust for that? Because again, in my experience, there was nobody helping us from a public health standpoint saying, hey, you got to take into consideration all these other things. They would all acknowledge those were important things to think about, but it was so easy to measure how many people got COVID. Well, not that easy. Actually, early on, we had to develop tests and get that all worked out. Okay, so there was a lot of work in front. There was a lot of uncertainty around that. But once we got testing down and our contact tracing, it was pretty easy to keep track of cases. We could keep track of, once we got the systems put in place, how many people were going to the hospital, how many people were dying in the hospital or dying in general. So we could track those numbers pretty easily. But some of the numbers we didn't see at all. And some of the numbers were delayed effects. So for example, if you think about things like suicide rates or drug overdose deaths, those are all, even in normal years, we don't get those numbers until months later because of the way our tracking systems work. How can we change that to do better next time? Or what else can we do differently so that elected officials such as myself can get a broader view of how to address these issues?
Yeah, I mean, the analogy I think of is, the Vietnam War, right? You're tracking the number of casualties on the other side as a measure of success in the war. One number. It's easy to think about the number and say, okay, am I making progress or not making progress by looking at that one set of numbers? When in fact, what you need is a much broader picture. And some of the things are hard to measure, or hard to see. So I'll give you another example. We kept our children out of school. The estimates from published research is that when you keep kids out of school, they're gonna lead shorter, less healthy lives. They're going to be poorer as a result of being kept out of school, even for short periods of time. That plays itself out over a generation, right?
Yeah.
The estimate was in the literature is that something on the order of 5 million life years were taken from our kids as a consequence of keeping kids out of school for just the spring. Yeah. Now that is a number that came out in January of this year. Yeah,
a little bit late, right?
Yeah, exactly. What it takes is imagination, right? You have to say to yourself, if I do this, what are the other consequences going to be? And our public health officials have lacked that imagination the entire epidemic. They've been so focused on COVID, and I think as a result, they're sort of misinformed both the public at large and leaders like you, because it's our job to provide that kind of broader picture, right?
So,
That's our
yeah.
profession.
So let me ask you a question on this one. So, what we learned, obviously the first experience was Wuhan and the Chinese government really shutting things down, like literally scary pictures of like welding apartment doors shut, right? So you couldn't get out of the building. By the way, fire hazard, right? That building gets on fire, all those people are going to die. Let's talk about other things. But so we saw that in Wuhan, we saw the lockdowns in Milan. How much of a difference did it make that we saw the initial response being lockdowns in places like Wuhan and Milan? Because that's where the first experience we saw. What if it had been the first place we saw this was Sweden, where they didn't really do a lockdown? They were much more focusing on protecting older populations. A lot of actually what you were really advocating for, like try and protect the most vulnerable and try to let other people live a more normal life. What had happened if this outbreak had not been in Milan first, for example, but maybe in Sweden, and they'd taken that approach? Would that have changed the way we thought about lockdowns and how we approach fighting this pandemic?
I do think that's true. I mean, I think if you look at the pandemic plans that existed before, the World Health Organization, the CDC, they didn't emphasize lockdowns. If they talked about school closures, it was like a very short period of time in places where you had very high community spread. And again, for very short periods of time. They don't recommend business closures. They don't recommend almost any of the more draconian things we ended up doing. If you think about what changed, that experience of China with an apparently successful lockdown, a lockdown apparently successfully reducing the number of cases to almost zero, that played an enormously important role in the imagination of policymakers worldwide. And the idea was like, and I heard my fellow economists actually talk about this to some extent. Well, we can't have our economy going until we've gotten rid of the virus. Well, we just do. We get rid of the virus. How? Let's copy the Chinese model, and then you can compare it against Italy, where you see body bags lined up in churches. They didn't lock down hard enough or fast enough, and you compare and contrast. Say, well, we need to do that. We need to bite the bullet and lock down. I think there was a sharp change in March of last year, middle of March of last year, where we went from, well, we have to disrupt society as little as possible while protecting the vulnerable. That was the pre-pandemic plan, really. Take the virus seriously, but you can't pretend like you can contain it to zero. And as you can see, the track record of trying to contain it to zero has been very ineffective. Europe and the Americas, it's spread everywhere. This is a virus we'll have with us forever.
Yeah, it's a virus.
Yes.
That's what they do.
Yeah, unfortunately also.
Yeah.
I mean, I think that the Chinese model was a disaster for the world at large. That model of let's lock down to get rid of the virus, it played too large a role in our imagination and still continues to play a role. I think a lot of the people that are still pushing for lockdowns in the UK, they were supposed to have Freedom Day earlier this month. They delayed the lockdown kept the lockdown in place for yet another month. They're still thinking about getting rid of the virus, which is just a fool's errand.
Yeah. Actually, I will say that's one of the great pieces of advice I got early on from some of our health officials at the University of Nebraska Medical Center. They said, hey, this is a virus, Governor. You cannot stop it. What you can do is slow it down enough so that you can preserve your hospital capacity. And so what we did here in Nebraska, obviously, as much of the world, when President Trump said, hey, we're going to do, a stay-at-home order, we want everybody to stay home. We didn't do a stay-at-home order here in Nebraska, but we did ask people to stay home. And we just didn't make it a public health decree or anything like that, a directed health measure. But, so we did try to, in that time where we were asking people to limit their mobility, we tried to build the resources, get our hospitals, the PPE, for example, they needed. Get our testing system set up in place, get our contact tracers set up so we could make sure we could track who's got the virus and ask them to stay home. And frankly, the other thing too we saw in April was the dramatic increase in the way our hospitals, our doctors and nurses were able to treat the virus. So for example, in Grand Island, which is a town of about 50,000 people with a fair number of meat processing plants, that they started getting hit early on in our state, not necessarily in our big urban areas, which is kind of interesting, but we saw a high mortality rate the first week that those patients were coming in. And it literally dropped the second week and dropped again the third week and the fourth week. Our medical establishment really quickly adapted to figure out how do we treat these folks to give them a much better chance at surviving the virus. And so by the time we got into summer, we actually had a lot of the resources built up that when we hit our big surge again in the fall, we didn't even think about doing a lockdown again because we had the resources, we had all those things in place. We still saw a lot of hospitalizations, obviously, and a lot of people died because it's still a dangerous virus if you're 65 or older, for example. But I think that's one of the things that there was so much we didn't know early on, but we did learn some of that stuff. But then some people, like you were using the example in the UK, didn't learn from it. And in fact, I think you were part of one of the co-creators of the Great Barrington Declaration, right? That was talking more about trying to protect people. Can you talk a little bit about how that all evolved and how you saw this going through the pandemic early on, like in early March, April, then coming through the summer that led up to the Great Barrington Declaration?
Sure. So in the early days of the epidemic, we really didn't know how deadly the disease was. A lot of the controversy in the early days of the epidemic had to do with how widespread is it, right? So if it's a disease that spreads not that well, but is very deadly, well, you have one set of policies that work. There you can isolate people who have it, contact trace around to make sure that the disease doesn't spread, and the deadliness of the virus actually, in some sense, slows the spread of the disease, because if you get very sick, you stay at home, you don't spread it very well. On the other hand, this could also have been, based on the data we had, a virus that spread quite widely and killed a certain group of people. Right? In this case, that's what it turned out to be, a disease that spreads quite widely, very readily. It's a very infectious disease, but it's most deadly for people who are over 65, maybe over 60, or with certain chronic conditions. Right there, the policy has to be very, very different, or the strategy has to be very, very different. Right, trying to contain the virus from spreading all over the place is basically not possible. Right? You end up like destroying too many lives in order to try to do it, and you still end up with the disease spreading. But who's vulnerable? It's the older people, and in some sense, that's a weakness of the virus that we should use to go after it. Right, the virus by protecting the vulnerable, you defang the virus. You no longer let the virus come and hurt the people that is most liable to hurt. So in the early epidemic, I worked on a series of studies to try to measure how widely the virus had spread. I worked on a study in Santa Clara County, California, where I live, in LA County, and we found was that the number of infections were something like 40 times or 50 times more than the number of cases identified. Of course, in the early days of the epidemic, as you said, Governor, we didn't have so many testing resources. It's not surprising that there's lots of infections around. But what that meant is that we didn't know what the public health authorities saw was only a small tip of the iceberg, if you will, of all the infections. And it also meant that the virus was less deadly than we had realized in the early days. Right. So instead of being a virus that kills you, 3 or 4% of the time you get infected, that's what the World Health Organization said. In fact, it's more like on the order of 0.2% of the time. So 99.8% of the time you survive if you're infected. And not only that, but if you're over 65, over 70, well, it's a 5% mortality, which is pretty high, 5 or 6%. But if you're under 70, it's a 0.05. 99.95% mortality or survival if you're under 670. 99.95. How much would you disrupt your life around that? Would you stop sending your kids to school around that? I think ex ante we wouldn't have done that. Please, Governor.
No, go ahead. I agree. I think that's part of it is trying to come up with how do we do a better job of communicating the risk, because one of the things, if you tell somebody, and we've looked at our data here in Nebraska, for example, if you're 0 to 9 years old, you're twice as likely to die in a car accident as you are to die from COVID. That means that when you put your kid in the car to take him to school, you're putting them at twice at risk than what if they got COVID and dying. So how many parents are going to start walking their kids to school, right? Well, nobody's going to start doing that, right? Because there is risk we accept in life. Yeah. Yet if you look at some of the surveys, some people, I can't remember exact percent, but there's a huge percentage of even Republicans who thought you had a 50% chance of going to the hospital if you got this disease.
Yeah. I mean, it's really amazing. I mean, it's and what's more on the order of like 4 or 5% if you get the disease, right? It's a very, very different risk than people. I mean, I think you can understand why people have this misperception. The media played this up like crazy, like this is the deadliest pandemic we've seen since the 1918 flu, right? I mean, so I think, and I completely agree with you, Governor. The idea that we should give people some sense of what the risks are relative to what they're already taking is a good way to do this, right? So I think that, like in the early days, people started to jump to the flu as an example, right? In fact, more children died last year of the flu than from COVID. The flu poses a bigger risk than COVID to children.
Yeah.
It's fact, and yet we send our kids to school all the. I mean, I happily send my kids to school even though they risk the flu.
Yeah.
So I think putting that in perspective, I think was really worthwhile. But yet somehow, like last year, what happened was that if you tried to put it in perspective, you were somehow a denier, right? Like it was really like you were silenced and shut it down. But at the same time, this is a very deadly disease for older people, and we should take it seriously. Like in Sweden, actually I think did generally quite a good response. But in the early days of the epidemic, they didn't take seriously the risk to older people in nursing homes, just like we didn't in New York or New Jersey or Pennsylvania. And in Stockholm, there were nursing homes where the disease had major outbreaks, led to a lot of death. I think so it's a challenging communication problem. On the one hand, you really do need to live your normal life. You don't harm the lives of children or young people in order to suppress a disease that really doesn't harm them as much as the suppression itself harms them. And on the other hand, you have to take seriously the fact that it's deadly to older people. And so there's this two-tier kind of approach that needed the communication that needed to be told. Instead, what happened was we panicked the population at large. And the Great Barrington Declaration. This was something we wrote in October with Sunetra Gupta in Oxford and Martin Kulldorff at Harvard. It's Great Barrington because it's a town in Massachusetts where we met. Anyway, so we found this. Basically what we said was like, look, it doesn't make sense to have a unified lockdown when you're addressing a disease that affects a particular part of the population. Protect that part of the population. Do everything you can to protect nursing homes. Do everything you can to give people living in the community, older people living in the community, we said if you're an essential, let's say you're a clerk and you're 65, right? You're still working. Well, we didn't think about protecting you, even though you're really at high risk.
Right. Yeah.
You go out to work. Or like if you're living in a multi-generational home, we used hotels to house homeless people during the pandemic. We could have also provided them to older people living in multi-generational homes. If someone at their house gets sick, they can have a temporary place to stay. Right? There are things like this where you can, if you think about it, you want to do it because we've identified those as the vulnerable people. You shape your policies around that. We spent trillions of dollars. I mean, instead of locking down on those trillions of dollars, we could take that money and spend it on protecting the vulnerable. We would have done a lot better, I think, just as a country. And of course, some places did better than others. Like some places are still, I mean, like California, we just only recently lifted the lockdown. I don't know who we were protecting. Instead, we just kept our kids out of school.
Yeah. Yeah. And frankly, if you look at the data for no benefit, if you look at, for example, deaths per 100,000 in California, you can't really see that the lockdown actually made any difference in their numbers. They're higher than, I think California's about the middle of the pack when you look at it.
Yeah, well, actually, so I just ran the numbers for this in preparation for the podcast for California and Nebraska. And I'll tell you, California, if you look at the age-adjusted mortality from COVID per capita, California did worse than Nebraska.
Yeah.
Right? So California did worse than Nebraska for age-adjusted mortality in COVID. It doesn't make any sense. So California, you're right, absolutely middle of the pack, whereas Nebraska's did quite well.
Yeah.
And yet California did lock down, and Nebraska, you had a much more measured response.
And we were like the number 6 state for kids in school this past school year.
Yeah. No, I mean that's which is a huge benefit that'll last. I mean, your Nebraska kids are going to be in much better shape in years to come than California kids. And what did we accomplish? We didn't protect our older population by doing that. We just harmed our young.
Yeah. So why do you think, because there was a lot of pushback on that Great Barrington Declaration, which was, when I was looking at it, was like, well, this is kind of what we're doing already. So I'm a little biased, right? Because I'm like, this is kind of what we did. But But why do you think there was so much pushback on this from, again, if we're talking about science, and I'm a little biased because I'm a biology degree major, so undergrad, a little bit of experience, a little bit of a knowledge of like the scientific method and how it's supposed to be about, debate and theories and defending your theses and all that sort of thing. Why did you get so much pushback, and why did it, if you were even just trying to propose other things to do it, you were proclaimed to be a denier and blah, 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 blah. Why do you think that happened?
I mean, I was actually frankly shocked by it. What I expected was, I mean, the ideas themselves are not actually all that original, frankly. Like this is the old pandemic plans. It's basically common sense applied to this particular situation, right? So what I was expecting was that scientists and public health people would engage with us and would tell us, would work with us to say, okay, well, how can we protect the vulnerable? Like, isn't that what we're supposed to be doing, is protecting the vulnerable? And instead, we had this like amazing Dr. Fauci on his reaction to this was that it's nonsense, that it's in effect letting the virus rip through the population, which is the exact opposite of what we wanted to do. What we wanted to do is protect the vulnerable from the virus. In a sense, isolate the vulnerable from the virus. And in fact, and if you look at what we did with the vaccines, we prioritized the vulnerable first.
Right.
In fact, the states that most rapidly vaccinated the older population by prioritizing vulnerable has had the best outcomes during this winter wave.
Yeah.
So I think this is one of these things where like the scientific community had jumped behind the lockdowns, and a lot of professional reputations were at stake around the efficacy of those lockdowns. And the fact that there would be people on that would say, reasonable people that would say, look, this is the wrong response. Well, that meant that we just spent, it was in October we released it, like 6 months of very, very harmful things when there was an alternate policy available that would have had better results. I mean, it's hard to like say you're wrong, I guess. I think that's part of it. The other aspect of it, I do think there was like, people were so scared of the virus. And the idea of a lockdown is, I mean, since it's beguiling, it's like we can just hide ourselves away and the virus, everything will be fine.
Right.
What we've learned, I think, of anything in the past year and a half is that that's not possible, right? Maybe if you're part of if you have a job like mine where I can work from home or whatever. Although I haven't, I've worked from my office, but it may be. But for most of us, that's not possible. We have to feed our families. We have to educate our kids. We have to live our lives. And we are meant to live in community with one another. We're not meant to be isolated from one another. I think that lesson was a hard lesson for many in the public health community and the scientific community to learn.
Yeah, I was going to say, I remember a story about a woman in Chicago who was like 30 years old, had claimed she had worked from home the entire time, had all her groceries delivered, caught the virus and had to have a double lung transplant. And which of course is an outlier result anyway, but of course the media all played it up. And what it did, I think, was just stoke more fear when other people could have looked at that and said, see, it's a virus. Even if you do all these measures to stay at home, you're still got a chance of catching it. So that's not the solution to lock down that way. We have to think about other things we can do to be able to try and manage this in a way that we don't sacrifice with everybody being home all the time, because at your point, we can't do that. We just, as a society, we can't function that way.
Yeah, and as like we started the conversation with, there are other priorities in public health that get harmed as a result. So on net, I mean, I think a lot of the push, like the early days was like, well, we're balancing the economy versus lives, but it wasn't economy versus lives. It was actually lives versus lives.
Yeah.
Right. It's hundreds of millions of lives affected, billions of people's lives affected, and the health of billions affected by these lockdowns negatively. Well, that counts. That should count for something, right? So I think it was a combination of like a sort of incorrect framing of the trade-off, alongside the fear, and then the protection of professional reputations that led to the pushback we saw with the Great Barrington Declaration.
Yeah. So there are still people talking about, and we're thinking about how to come up with strategies here. I got asked, for example, on one of my public health calls that I have with my local public health people about a superintendent who wants to do masks next fall. And I'm like, why would you do that? There's no reason to. And so the question is, so you still have people talking about masks, talking about, some schools, like Creighton University originally had a policy where every student had to get vaccinated. What about that? What are going to be some of the ongoing ramifications of the things we've talked about with regard to how we handle the pandemic? And do you see long-term sort of social impacts to the way we handle this pandemic? Is there going to be a heightened state of fear from people? Or are people going to quickly go back to the way it used to be? What do you think?
So I do think people will eventually go back to the way it'll be, but I don't think it'll be quickly because it's, you have 16 months of fear. It's hard to undo that programming. I think the masks in the fall and the mandated vaccines, the question is, why are we seeing this demand on young people again?
Yeah.
As if they're the key focus of the spread. Like, the only I can think of a charitable explanation. The charitable explanation is you think that they're at risk, but if the facts are that they're not particularly at risk. The rates of mortality and bad outcomes for young people are quite low relative to other risks they face in their lives. And the other thing you can say is, well, maybe people think that the masks on children are a costless thing. We may as well just do it. Why not? Seems prudent. But they're not costless, Governor. The masks on children harm their development, right? So the World Health Organization, for instance, recommends against masks in very young children because it reduces it. They're supposed to have. They're supposed to see the faces of their parents. They're supposed to smile at each other. They're supposed to it harms their social and emotional development. And of course, there's the mask. Asking young kids to wear masks. They'll come home with snot on like they have snot on their. I had young kids once.
Yeah.
I still. So I guess
they're walking petri dishes, right?
Yeah. So I like to. I think of that as like a hygienic thing to ask is crazy. I think. So I think there's costs, right, on one side where the kids themselves are harmed, and what's the benefit? The disease doesn't spread among young kids. Well, we have already protected the old. The young kids don't spread the disease to the old very efficiently, anyways. And now that the old are protected with the vaccines, what benefit is there? Basic economics. There's no marginal benefit and no marginal cost. You just don't do the thing.
Right. Yeah, no, that's why I was asking the question. Like, I just don't get why you even think this is necessary. Again, going back to especially our data in Nebraska, twice as likely to die in a car accident. Are you going to start telling the kids, don't drive to school?
Yeah.
Right.
I think completely agree, Governor. It doesn't make much sense, and yet we've focused on this as if it were the most important thing. Like, it's almost like in the back of our heads we think, well, if we just get enough people taking all of these measures, we can get the virus to go away. It's still in the back of our heads as something that we can get rid of, and it's just not. We have to accept that the virus is here, and vulnerable people, we still need to think about them. Actually, the U.S. should celebrate this. We've done a fantastic job vaccinating the old. I think 80+% of the older population is now vaccinated, protected from the virus, and the virus. It's at low levels both because of that and also because of essentially herd immunity. We've had a lot of people already infected that are immune, that are walking around, and so that also protects everybody. I think we should be celebrating. We should declare like what a VV Day, Virus Victory Day, or something.
Yeah. So let me ask you a question because it's a virus, right? It's fair to say this thing is going to be with us forever now, right? I mean, again, you can't get rid of a virus that way. You can develop immunity to it, but you can't get rid of it. So what's the long-term implication for society as we go forward? You talked about protecting vulnerable people. Is this something where we just add this to the list like measles, mumps, rubella? Got to get your COVID vaccine, especially if you're 65 years or older, right?
Yeah,
and then you just you say, well, we move on and we take that risk that the vaccine doesn't protect you, just like we take the risk when you get into a car, you could be in a car accident, or you could get struck by lightning, or a number of other health risks we take just stepping outside of our home or even staying in our home.
Yeah, I mean, this is now, I think, the 5th circulating coronavirus. That's what it is, and it'll be with us, to the end of time. I think the very long run, what happens is it'll be just like the other circulating coronaviruses. You'll get the virus when you're little. It won't hurt you. You'll build immunity to it. Then you get reinfected a few years later, it'll be a little cold. And a few years later, it'll be a cold. And by the time you're 65 or 70 and you get it, well, you've built this immune memory that protects you forever again. So it won't cause this kind of dislocation and death that it caused this past year ever again. But it will be here forever. And there'll still be some people who don't have that immune memory because they weren't vaccinated or they didn't get it, that are still vulnerable, especially older people. That if you're older and you're listening to this, please get the vaccine. It's such a good idea.
Vaccines work.
Yes, they do work.
Vaccines work. Turns out vaccines work. Actually, we got a great story here in Nebraska about that. We have I will say the long-term care facilities in Nebraska really did an outstanding job here. But we had one in Kearney, Nebraska, where about 60% of the staff had been vaccinated, almost all the residents, but 40% of the staff had not. Somebody brought in the coronavirus. They had a case, so they tested everybody in the facility. 23 residents tested positive, 21 no symptoms, 2 had very mild symptoms, but nobody went to the hospital, which, if that had happened last November, different story entirely.
No, I think the vaccines in the older population is really critical. Now, will we need the vaccines in the long run, say 10 years from now? I'm not sure about that. There's still a lot of uncertainties about the way the virus evolves, and the vaccines themselves can change over time in order to address the viral evolution. But there's also immunity induced by natural infection, and also the vaccines that could be quite long lasting. We don't know for the vaccines, especially yet, how long lasting. What's coming to the fore with the natural immunity is it seems like it's very protective. Even the vaccines are protective against the variants that we've seen to date. It's protective there's 2 kinds of protection you can think of. One is immunizing protection, means you get the vaccine or your natural immunity, you get challenged with the virus again, and you have nothing. The virus doesn't infect you at all. That's neutralizing immunity. Then there's also protective immunity, where you can still get infected a second time, even after you've got the virus, even after you've recovered from the virus, you have natural immunity or vaccine, but the reinfection doesn't really produce very much in the way of symptoms, just like you were describing in that long-term care facility. It looks like both natural immunity and the vaccines give you protective immunity. It's like it turns the disease into a cold.
Right.
It's unclear whether it's going to give you neutralizing immunity, especially against the variants. But if that's true, the vaccines are not a tool to get to zero COVID. They're only a tool for focused protection.
Right. Yeah. Okay, that makes sense. So let me switch gears here a little bit, because this is something else that has changed, or maybe people still think lockdowns were the answer, and you and I are kind of in the outlier position on this. But another position that has changed is how the virus got here in the first place. So you may recall back last year, people were talking about the lab in Wuhan that NIH had funded and that was doing enhancement research on these viruses, and that there was a question about whether it had accidentally escaped from the lab or whether it came from an animal. And everybody, like Tom Cotton, our U.S. Senator, or not our U.S. Senator, but he's U.S. Senator from Arkansas, came up and said, was questioning about this. And the Washington Post said, well, this has been debunked. This is false. It really came down on him hard. And really falsely too, because they basically made it sound like the research in March of 2020 had definitively shown that there's no way it could come from the Wuhan lab, and that was absolutely false. So the Washington Post was just an egregious error on this, of accusing him like that this hasn't been debunked. It had not been debunked. You might disagree with it, but there was no science to prove it had been debunked. Well, now here we are, more than a year later, and the Biden administration is re-looking into this. So what has changed over that year that people are now willing to accept that, at least a theory that this might have happened in Wuhan? And does it make a difference about how we protect ourselves against it? Certainly from a national security standpoint, maybe there's implications. But I'd like to get your perspective on, if it did come from the lab versus from jumping to an animal, how does that change how we respond to it, both from a health standpoint, but also maybe from a, thinking a policy standpoint and how we fund things standpoint?
Yeah, so I obviously don't know whether it came from a lab or from animals.
Oh, I thought you were going to actually announce that you knew on this program. Darn, I thought we were going to have a scoop.
You got to say what you don't know, right?
Right. Yeah.
But your question is a really good one. Like, what difference does it make?
Why does it matter?
right? It makes quite a difference, right? So if you think that it came from a set of gain of function experiments, well, essentially what that means is that you've jumped ahead in the evolutionary process, and so you've created a virus that's like tuned to infecting human cells. Well, that kind of virus is going to, in a sense, because it's already tuned to infect human cells, is going to change less over time. So the variants that you get will be closer, in some sense, in some evolutionary distance sense, to the initial virus. In a sense, you have to you worry less about the evolution of it, and you can focus on what to do with the virus as it is. Whereas if you have a virus that's made an evolutionary jump and it just barely infects humans, it's going to have a different nature in some sense. Like, this is all very, very high level theory, but I mean, in some sense, it does change how we think about how to address the virus over the short, medium, and long terms. If it's one or the other. So that's in terms of like the public health response. There's another kind of sort of like national security science policy response that's also quite important, right? So why were these gain of function studies funded?
In the first place, right?
In the first place, right? So the argument was, going back now 20 some years, was that we don't know how likely it is that a virus can make a leap from an animal to a human. Well, how can we study that? Well, if we can change viruses we find in nature and ask how many changes we need to make so that it would infect a human cell, then we can get a sense of does it work or not? Is it likely or not that the virus will make a leap? Or do we need to worry about it? What not really sort of taken as seriously as probably should have been is, in the process of doing this experiment, you actually create conditions where someone in the lab can get the virus. It's infectious virus is really hard, even in high security labs. And so the risk of spreading the disease just by the fact of doing the experiment was, I don't think, taken as seriously as we ought to have. Now, there was some pauses in this. So the NIH actually stopped funding it for a while on the basis of this, but it's very clear that they actually continued to fund it.
Yeah, I think Obama actually put in an order or whatever to stop the funding of this gain of function or whatever type research, but NIH, at least from what I read, ignored that and continued to fund it. So
yeah, so there was actually in 2015 there was a moratorium put in by the NIH, but they put in exceptions. So, like, for instance, if Dr. Fauci or Dr. Collins, who's the head of NIH, said, okay, this is worth the risk, then they still funded it. And then 2017, there was a formal process where they lifted the moratorium, but there had to be a big formal process to prove that the research was worth the risk. And I actually did a search. I mean, the NIH has continued to fund it since 2017. There's no question of this kind of work. I think we need a national conversation whether this is a good idea or not.
Yeah, no kidding. It sounds like, at least based upon our recent experience, if we can determine that it actually came from the lab and not from an animal, it's a bad idea.
I think so.
And I also heard, and I don't know how much I read someplace. So you can read so many things, but the actual security at the Wuhan lab really wasn't high security. That it was only kind of like a medium level security from the standpoint of biosecurity. And so it wasn't like a high level lab where everybody's in the suction gowns and stuff like that. That was actually much lower than that. Is that accurate?
From what I understand, what I've read is that there are different levels of they're called BSL levels,
right.
Biosafety levels in the Wuhan lab. So there's some labs that had very, very high and some labs that had low. And the insinuation is, I don't know how to assess this, is that the experiments on the coronavirus were done in relatively low security places as opposed to the high security places. I don't, again, hard to assess that.
Well, that would be another indication of why it's important we find out where this came from, because if that was the case, then again, that would lead to, the implication would be that, hey, if this gain of function type research needs to be in the really high security because it was done in the lower security, obviously, and it escaped from the lab, that's a problem. So another way that it's important to know where it came from so we can make changes to prevent this from happening again.
Yeah, I mean, I think if it is a lab leak and the U.S. helped fund this lab and China put in didn't like sort of oversee it sort of effectively. I mean, it's hard to. I don't do politics, but I can imagine that's going to have an enormous political impact.
That would have a fallout, yes.
Yes.
Well, what about the next pandemic? I mean, nobody wants to talk about the next pandemic, but what do we learn from this that we can apply to the next one?
Well, I think the key thing is to me that one thing I've learned is decision making under panic and is just devastatingly bad.
And by the way, that's not a new lesson.
I never thought of it. I was like, yes, I know. I was thinking about NASA, right? So like, I watched Apollo 13
Right.
like a couple years ago, and I remember just like struck that that they had in place during the most panic moments, they had in place like a checklist or some like list of things that they did. They just followed it without basically without even thinking, because they'd already done their thinking.
Right.
And we need something like that, because the decision making under panic and uncertainty when another virus hits or another pandemic hits is going to be at least as bad.
Yeah.
And we need like a NASA let's follow this guideline and not let ourselves panic around this, because that's what I think in large part what happened in March of last year. And I don't know. I mean, I think the other thing is I think the pre-pandemic plans, which have worked for 100 years, protect the vulnerable, give people good advice about risks, and let people work really hard to maintain normal life, disrupt it as little as possible while protecting the vulnerable. I think that we don't know who the vulnerable are going to be in the next pandemic. May not be elderly, but in any case, that whoever they are, that principle I think will work in any pandemic.
Yeah. Yeah. All right. Well, I mean, this is a little bit dangerous question to ask. But I guess I always have the opportunity to edit it out if I want. How did Nebraska do? What was your assessment of how Nebraska handled this versus some other states?
I thought Nebraska did really well. I mean, I think probably to me, if I'm looking at Nebraska's response, the single best thing that you all did is keep your kids in school through the whole year, right? That was an enormous achievement in the face of what must have been a tremendous pressure to not. I mean, I saw that pressure in California. I saw that pressure in other states where I worked, and so I think that is a tremendous. You've done something for your children that you can be quite proud of. And as far as COVID control, it's been quite good. For the most part, it's for the age-adjusted mortality rates, you're in the top third in the nation. And so I think as far as like balancing the risk of COVID to the vulnerable populations while keeping normal function going, I think Nebraska did quite well. I mean, I'm really much less happy with how California performed where I live. I mean, we basically failed on both. We had very, sort of middle of the pack COVID response, elderly people still dying at very high rates. My mom didn't get, my 80-year-old mom living in Los Angeles, didn't get her COVID vaccine until late March. Sort of a very slow response to deploying the vaccine. And we also harmed our young.
Yeah, by keeping them out of school.
Schools. So I think, Nebraska, I think I wish I'd lived in Nebraska this year rather than California. Well,
it was interesting, just as an aside. First of all, I got to give credit to our educators. Our school systems did a wonderful job, a phenomenal job. Teachers worked double shift, accommodating kids who wanted to stay home and do remote learning while allowing for kids in the classrooms, putting together plans. The Commissioner of Education doesn't report to me in Nebraska, so I had to work collaboratively with the Commissioner. But we set the expectation in July that kids were going back in classrooms, and educators really put together great plans for how to accommodate that. And so you saw just a lot of great work across our state to be able to make sure kids could have that option of being in classrooms. So I want to credit our educators, our teachers, our superintendents. Everybody just did a fantastic job on making that happen. So we got no complaints about the cooperation there. Well, I can complain, but it wouldn't do me any good. They don't report to me. So.
Well, I think that's a really important point, Governor. Like, there's no perfection in a pandemic like this, right? There's no matter who you are, there's going to be mistakes. We own up to them and then move on and try to learn from them. I think a lot of the problem has been the mistakes that many places have made. They've sort of doubled down on and pretend like they're not mistakes. And I hope we can, when we do, and we need desperately some kind of commission to look at this and do an evaluation, because like in medicine we do this. Like if a patient dies, you have a conference to say, okay, what went wrong? It's an honest conference, and then from that you learn, and hopefully the next time you do better. We need something like that here.
Yeah, let me tell you, with politicians, it's not quite so easy to do that. A lot of politicians have a hard time acknowledging, I made a mistake and we got to go back and correct it. We here in Nebraska, we were supposed to have a lot of contact tracers, and we didn't get them hired the way we thought when we saw a surge. And I had to step up and say, "Hey, we dropped the ball on this. We have to step up and get this fixed." But typically, you don't see politicians wanting to step up and say, "Hey, we made a course error. We got to make a correction here." But I think that if you explain to people and you lay out the data for, "Hey, here's what we thought. Here's the data we've got now, and why we're changing that, and this is why we're making these changes," you can explain that to people, and people will understand. They'll get it.
I think people like to be treated like adults. I mean, like everyone understands this is a time of great uncertainty. No one's expecting perfection. I think what people are expecting is honesty. People are expecting changing in the face of new data. People are expecting some sense of like you have a broad vision. I mean, I think not much more you can ask for.
Yeah. Well, that sounds like a great place for us to end this, since we're about running out of time anyway. But how can people follow along with what you're doing, Dr. Bhattacharya? Do you have a Facebook page? Because I know that you're also getting censored on all sorts of things, but how can people follow along with what you're doing?
I don't know how people put up with Twitter, because it filled me with like unhappiness just to look at the thing.
Yeah, I never read any of those comment stuff. That's just soul sucking.
But I am doing this project called collateralglobal.org. Collateralglobal.org. And if you go to the webpage, I'm the editor-in-chief. We're basically, what we're doing is we're documenting lockdown, what the harms of the lockdown have been, both in the scientific literature and people's stories, videos, powerful stories, actually. So if you have a chance, whoever's listening, go take a look at collateralglobal.org. And actually, there's opportunities to get involved in this project. I think this is an important thing for be able to tell people sort of what happened during the lockdown. Those are real harms that have happened, and I think keeping that in mind is going to be important going forward for the next pandemic.
Yeah, especially as we think about our future planning. Well, great. Well, hey, thank you very much for joining us, and I want to thank all of again, Jay, I really appreciate you taking the time to talk about this stuff, and I really appreciate all of our listeners out there tuning back into the Nebraska Way podcast. We're very excited to be back on the air again to be able to bring you great guests like Dr. Jay Bhattacharya from Stanford University. We appreciate it so much. And of course, you can follow us along at here at the state of Nebraska on my Facebook page. You can go to Twitter at Gov Ricketts. And so what else we got? Oh, we got Instagram. So we got all sorts of cool ways. You can email us at pete.ricketts@nebraska.gov. And I'm trying to think again if there's anything else that we need to say here as we wrap up. I think we got it all. At Gov Ricketts on Twitter. And certainly, please keep tuning in. We're going to continue to have great guests. And Jay, once again, thank you so much for your time this afternoon. We really appreciate it. It was great. We've actually never met in person, but it was great at least being able to see you this time as we had the conversation. So thanks very much.
Good friends in Nebraska. Maybe next time.
All right. Well, if you're ever in town, you got to let me know.
I will. Thank you. Thank you, Governor. It was a great pleasure.
Yep. Thanks a lot. You have a great one.
Bye now.
Paid for by Pete Ricketts for Governor, 1610 N Street, Suite 100, Lincoln, Nebraska, 68508.